Hi, everyone. Welcome to today's program. I'm Lori Smetanka, the Executive Director of the National Consumer Voice for Quality Long-Term Care. And I know folks are coming in on Facebook Live as well as coming in on Zoom. So we are looking forward to having you all here today to join us in our conversation with Kelly Bagby. So today we're going to be talking about the use of drugs in nursing homes and other long-term care facility residents to sedate or control their actions or behavior, or used for caregiver convenience instead of providing good care. When used this way, the drugs become chemical restraints and they can cause serious harm or even death for the residents. So as I mentioned, our special guest today is Kelly Bagby, who is Vice President of AARP Foundation Litigation, where she manages the office's work related to health, hunger, housing, and human services. Kelly specializes in civil rights and disability rights, health law, and other public interest areas with an emphasis on litigation. She previously worked with the Office of Counsel for the Office of Inspector General for the Department of Health and Human Services, as well as with a couple disability rights organizations in DC and Maryland. And Kelly has a wide range of experiences in both federal and state courts in dealing with topics related to the care of the elderly. So welcome, Kelly. Glad to have you here today.
Thanks, Lori. Wonderful to be here.
So tell us a little bit about the work of the AARP Foundation and your role there so people get to know who you are.
Well, sure, I'd love to. So AARP Foundation is the nonprofit arm of AARP, and we do work on behalf of low-income people who are 50 years of age and older in a host of areas that impact their lives. So their challenges around food security, around housing, around social isolation. Those are areas where we do a lot of different work trying to connect people with employment opportunities who have fallen out of the workforce, and also help prepare people's taxes. We provide tax support to low-income people all over the country. So the AARP litigation group is a team of, a small but mighty team of attorneys that does work in a host of areas around housing, around age discrimination, around pension and ERISA work, different benefits and consumer protection issues, reverse mortgage issues. But the team that I work with is really focused on healthcare, on elder abuse issues that impact people in nursing facilities and in other long-term care settings. We try to keep people from being forced against their will from having to go into nursing facilities, but we also and try to help them to age in place with dignity and pursuant to their own choices. But we've, over the years, realized that there are many people who are going to be forced to go into nursing facilities, and we want the care there to be as high quality and appropriate to their needs as possible. So we've done a series of cases that sort of led us to where we are with you and with Consumer Voice around a grant that, that we are working on together around trying to address the inappropriate use of antipsychotic drugs with people who have, especially people who have dementia, but also the inappropriate use of antipsychotics generally, older people.
So the work that you do is so important, and you do have such a mighty team that you work with. There's such a great group of people. But talk to us a little bit about the antipsychotic cases. What drew your interest in them, and why was this an issue that you felt was important as a foundation and association to address?
Well, I became very consumed with the issue at a Consumer Voice conference many years ago, and I was listening to all these people talking about how there was just this increased utilization of drugs in facilities. And having worked doing fraud cases for the federal government, I had seen a proliferation of the increased use of antipsychotic drugs in particular with older people. And there were a series of kickback cases that we had been involved in the federal government, where the Department of Justice had pursued these companies for off-label promotion of drugs with people for whom they're not clinically appropriate.
Mhm.
And so, people use drugs, all different things, off-label for a host of different reasons. But there have to be clinical guidelines around that. And you shouldn't be using drugs against the label. So a lot of the drugs that are being used, like risperidol, other drugs like that, are being used and they have a specific warning on those drugs that the FDA's highest warning is a warning that says, if used with people with dementia, you have an increased risk of death. So that increased risk of death is about 3 times more if it was used with a younger person. And the FDA tests are actually used, they only looked at people who are 65. So imagine you have someone who is 85.
Wow.
Other complicating medical conditions. The incidence of death and mortality, the risk of harm to them is so much greater than it would be even for a person who's 65 who does not have a mental health diagnosis. Obviously, antipsychotic drugs are lifesavers for people who need them.
Right.
But not clinically appropriate to give those drugs to people, then it is a chemical restraint. So we began looking at the Consumer Voice Conference, I don't even remember which year it was, probably maybe 10 years ago. I began asking advocates to keep a lookout for cases that I could bring or be involved in. And I found a great one in California, and thankfully a wonderful set of advocates allowed us to join their class action against a facility in California that had been, they had a psychiatrist that was just every single person that he served. They had about 240 patients over the course of 3 years. Every single one of those people was getting an antipsychotic drug with no informed consent at all.
Wow. I mean, and they're so dangerous, as you said. They've been proven to be so dangerous. This is one of those issues that I've been hearing about ever since I started this work more than 25 years ago. The use of chemical restraints was a big issue back then. And so it's been a problem for decades. And even now, the data is showing that more than 179,000 people in this country continue to be administered these antipsychotic drugs despite not having any clinical diagnoses. So the work that you've been doing around this is definitely so important. Go ahead.
Yeah, you too. I think that part of the way that we've helped to understand this is by talking to other advocates and physicians, people connected with Consumer Voice, who have really helped us to sort of take away this knee-jerk reaction, which is what it is. And with some chains and some facilities, it is just everybody's going to get these drugs. And but I think that what we should really stop and think about is, what is it that you're trying to treat? If what you're trying to do is silence someone, and if that's the goal, that is by definition a restraint, and it's a chemical one, then these drugs have mind-altering as well as physiologically altering impacts. And so if you don't take into consideration the side effects and monitor for the side effects and watch for them, and certainly be aware of them, but also watch for them aggressively, you can get a person to deteriorate. And many of my clients have deteriorated extraordinarily quickly, many of whom never could recover. Like within weeks, they were at the door.
So talk a little bit about what you've seen with respect to why these drugs are often prescribed off-label, or why people are using them as chemical restraints. What are some of the factors that apply to that?
That's an excellent question. I think that many people who are using these drugs widely don't see the label. The labels, a pharmacy is packaging up the drugs in a way that the label that the FDA has mandated is long since removed from the drugs. So many doctors have just always used them. And so then there's a familiarity with them. And if you have a person who has certain kinds of communication things that they're trying to tell you, maybe they're spitting, or they're yelling out, or they're hitting people, that might be because they've lost the ability to tell you with words that they are in pain, or that they have a fever, or that they're uncomfortable and don't know why, or they're scared, or they're lonely, or there are any number of socially isolated ways that people try to communicate when they maybe have lost the ability to swallow, so they can't speak as well. So there are a lot of different reasons why people have these manifestations that then somebody, in a nursing facility or in a long-term care setting, grabs for a bottle of drugs or writes a script for medicated response, as opposed to saying, okay, first thing is, let's evaluate whether there's something actually wrong, like medical. Are you constipated? When was the last drinks you had? Check, are you dehydrated? Let me look at the way your face looks. Are you in pain? Is there a broken bone somewhere? So the first place that people should stop and say, okay, someone is communicating something here. Our mutual friend who has been my expert and is on your board, Dr. Jonathan Evans, I love his quote where he says, all behavior is communication. So if I put my hand up, I'm trying to communicate to you. If I spit in a nursing facility, I'm not just doing that for the heck of it. There's something I'm trying to communicate. And so the part of the problem is we as people who are watching, and providers, unfortunately, who are overtaxed and understaffed, will make knee-jerk reactions to what they're seeing, as opposed to making a clear clinical evaluation, really assessing what it is they're seeing, and then trying to diagnose it rather than mute it. Like muting it is not the same.
No, absolutely. And I mean, you made a number of really important points there about the behavior being communication and, really thinking about what the person is trying to tell you, because for many people in nursing homes, particularly those with dementia, as the disease progresses, they lose ability to communicate verbally and even in some other ways. And so you really have to be cognizant that there are different ways of expressing themselves, that they are trying to communicate oftentimes through either reactions to what's being done to them or through actions that they're taking themselves. So that's a really important point. And I think that some of the reactions or actions that we see even causes a person sometimes to be at risk for being chemically restrained, would you say?
Oh, for sure. I mean, I think one of my clients in a case that we had just a year and a half ago, her dad got punched in the arm by another resident. And so he knew he didn't like this guy. He didn't remember all the details about why he didn't like him, but he knew he didn't like him. And so when the next opportunity came, he gave him a little sock back. And next thing you know, he's carted off to the ER, and he's in for a psych eval because, and so next they loaded him up with drugs in the hospital, drugs he'd never been on, took him off of all the dementia drugs he had been on, and then sent him back to the nursing facility with a whole new set of prescriptions. And very dangerous prescriptions. And he ended up developing Parkinson's as a result of shuffling behaviors and tremors, and nobody was monitoring them. So not only did they have the perfect storm of doing all these things wrong diagnostically, they also didn't monitor for side effects whatsoever, and didn't even when I took a deposition of the medical director, he was unaware that he should have been monitoring for side effects. And that kind of stuff is scary. That's scary that doctors aren't aware that these drugs are not clinically appropriate.
So clearly we need to do a lot more education of the medical community, the providers, as well as families and those that are advocating on behalf of residents. So that's why we were wanting to do this program. But another thing that you said was the staff that are overtaxed. Often it's a knee-jerk reaction to prescribe the drugs, but oftentimes you see it being prescribed when the staff are overtaxed. And so could you talk about that a little bit more?
Yeah, well, unfortunately, I fear that that's something that's going on right now behind closed doors in nursing facilities where there's such poor staffing going on. But when you don't have sufficient staff and there are a lot of, the residents remain the residents. They have their same needs day in, day out. and their needs with social isolation and fewer staff may exacerbate. And so they're the things that things they want attention on, and should have attention on, because that's what they're in a nursing facility for. Their daily care needs, their food, drinking, go to the bathroom, positioning, all those things they need staff for. And if you don't have staff and people's needs are going unmet, you're going to have more complaints. And the more complaints you have, the more the staff are feeling overwhelmed. And so this is a cycle that oftentimes has led, in our experience, to an increased use of these drugs with people who, because the staff is seeing, okay, I have all these people complaining simultaneously, and they're getting into arguments with each other, and we can't function like this. And so, and that's not the line staff's fault. That is the fault of the facility that allowed for the understaffing to get to that point. And so what happens then oftentimes is you see the facilities start just giving many more people these medications than even are than they're even can monitor for.
Yeah.
They're not paying attention at all. And these drugs cause what's called somnolence. So like where you get really drowsy and droopy, and you can't hold yourself up properly in your chair or on your bed. So people tend to fall more, because the more they are on these drugs, they have more risks of being unsteady on their feet, or falling out of a chair or out of a bed, or rolling off a bed, and they can break bones. And so there's a number of really dangerous things that happen. But I think, it's sort of the things you have to monitor against with when you have this problem are all things you need more staff, not less staff, to be able to monitor. So a lot of times our clients have lost interest in eating because there are so many drugs, and they, because they're not eating, they're losing weight. And if you're not monitoring people's weight loss, you could be basically pushing them towards an even more dangerous situation, and they become more delirious and they become more at risk. And so it's a cycle that keeps spinning and spinning and spinning until finally, people are not dying from the drugs. They're dying from the things the drugs do to them and their body, giving up, and eventually either dying of a heart attack because they've been dehydrated or malnourished for weeks.
Yeah. Yeah, it's so tragic when you hear about some of the results from the use of the drugs, and some of the ways that it plays out in people's bodies, and some of the reactions to them. But instead of that knee-jerk reaction of prescribing the drugs, or even thinking about what could be done instead to address the needs that the people are having. What have you found in your work that has been successful in, instead of the use of the drugs, in addressing people's needs, so that they aren't, not only are they having their needs met, but they're not exhibiting the actions or reactions that people are finding troublesome?
Right. Well, thankfully, I've been blessed enough to work with some really amazing experts who are extraordinarily well-versed in non-drug interventions that actually work. I mean, these like chemical restraints don't work. They just quiet down whatever it is disruptive. But there are things that do work, and that is usually it has more to do with a person with dementia in particular, trying to reroute them to something that is more engaging. If they're bored, try to get them to a situation where they're not going to be bored. If they're, like I said before, though, the first round of attack has to be make sure there's no underlying medical problem that's leading to this. But the organizations that have really been studying it I think there's some brilliant studies out there, and I think that may be the next thing that you and I work on this campaign, is trying to get as much information to people about what does work. But listening to what a person is actually trying to communicate is the first, obviously the diagnostic thing, but also if a person is because of their past life and experiences, they've convinced themselves that they're in a situation that is different than what they're actually in, that to deal with that confusion and meet them there. Like, I know that you guys have talked at your conferences about changing when people are having to get up at 6 in the morning, and they, really they maybe wanted to get up at 3 in the morning because they thought their day was beginning at 3 in the morning.
Right.
But because that messes up the facility schedule, there's no flexibility there, and then that makes people kind of burn bridges with staff. And so trying to meet people where they are and understand what what it is they're communicating, and not make them live an institutional life even though they're living in an institution. You can have some flexibility in the way you talk to people, and when you do that, that seems to have a much better impact. And I think that there's some wonderful nurses that I really love working with at the University of Pennsylvania, and they have really taught me that what you have to do is help nurses to be able to know what it is they're seeing. If nurses know what they're seeing, everything's going to go work better. If you train CNAs to recognize that that shuffling behavior is not a normal aging process, that's actually a sign that you are giving somebody a drug that they're having a bad reaction to. The more that you can train people to understand what it is that that they're seeing, the faster they could stop it and identify it. But you have to, if people don't even know what they're looking for, that is a tremendous problem. And by the time you realize, it can be too late.
And I think that that's a great point. I mean, I think knowing the person and watching for changes in their condition, watching for changes in their behavior, and then starting to assess what it is that they might need, looking, at environmental factors, for example, like, are they sensitive to noise or cold or heat or interactions with other people? You mentioned the resident earlier who had a altercation with another person. There are some factors like that that could be affecting their behavior, as well as medical conditions that could be affecting it. And so it's really important for the staff to be looking at those behaviors. So training obviously is really critical, and being aware of the residents' individualized needs is really critical.
And getting good assessments of those needs, because I mean, with poor staffing also comes a lack of continuity of staffing, right? So if you have a different CNA every day, they're not going to know that this is not how you're normal, this is not your baseline behavior. Right. And so if you have continuous staffing of people who understand your needs, actually have read your assessments, and you have a good care plan, like those are critical. So we're all only as good as the tools we're given. And if the CNAs don't have the right tools and they have no real continuity with a resident, it's very difficult for them to recognize what they should be doing.
Right, absolutely. It's one of the reasons I think why we're so in favor of consistent assignment of staff for residents, because that does provide some of that continuity. So not only do you need the numbers, but you need the staff assigned to people on a daily basis so that they get to know them. So you've talked about a couple signs of, or examples of people, some of the symptoms that they're showing that indicate that there might be an issue, or that they might be chemically restrained, or having these drugs used. So can you talk a little bit about what some of those are?
Yeah, the tremors are the big one, but that's tremors like this, where your hands are shaking or your legs are shaking and someone just can't sit still. That's a very big one, but that's very Parkinsonian. Those can be reversed if you take someone off the drugs, but they can't always. So the difficulty swallowing is another. The lack of appetite is definitely a big one. Loss of weight is another. An unsteady gait, where they're walking and you just feel like they're just teetering. And obviously, I personally, when I have orthopedic problems, I have an unsteady gait. But that's not a normal process. If somebody just doesn't suddenly get that, if they never had those problems and they suddenly have an unsteady gait, that's a reason for great concern. Delirium is that's the catchphrase for it, but delirium is basically just confusion. If somebody just seems like they're having a hard time understanding what you're saying, or they need you to tell them the same thing, there are certain parts of that that are normal parts of dementia, and other parts of it that are not. But you should never expect that and if it does, I believe that if someone's dementia worsens dramatically quickly, that's a sign that you should worry and take action. But I think one of the things that you and I have talked about in the past, Lori, is, and I don't know that nursing facilities take advantage of this very much, is getting a baseline behavioral assessment for somebody. And if you really understand what their trigger events are, what are the things that put them off, as you were mentioning, noise or too much light or a weird schedule or someone they just don't get along with. If we could make sure that facilities and people out in the community were getting that sort of baseline evaluation of somebody when their behaviors change, it will help us to then track when something unusual happens. And I think that that's the problem, is when somebody is in a nursing facility, we assume they're going to get worse, and that's not necessarily, it doesn't necessarily have to happen that way. It's often because of the use of these drugs that they do get worse.
I think what you said about like knowing the person and the baseline made me remember a resource that we had developed a few years ago about knowing the person. And so and it's something that could be done, upon admission or early on when you enter a facility, and the resident themselves could fill it out or their family members could fill it out. But it kind of talks about what were your daily habits, and what are things you like and dislike, and what are your normal maybe reactions or responses to things, so that it could help the staff know who you are, so that they could be more aware of changes in your behavior and when they might need to be concerned about some of those things.
Absolutely. And I think that with other populations that I've worked with, that's a much more demanded. It's imperative. And like if you're working with people with intellectual disabilities, you would assume you have that baseline information. But when you have people in nursing facilities, it's sort of like, oh, is that something we could do? And I think that we've relegated, I think, our older people in nursing facilities and in other long-term care settings to a place where they're just not getting as good a care as the COVID virus demonstrates.
Right.
That we've downgraded the importance of the quality of the services we're providing them, and it's unacceptable, and we shouldn't, none of us accept that.
Right. And certainly I think, you've mentioned the COVID crisis a couple times. I mean, we also, like you, are very concerned about what's happening in some of the facilities, and whether these drugs are being used more frequently with people with dementia as a means of keeping them quiet, keeping them contained. So that's a very serious concern. And it is one that we think families need to be paying attention to at this point. We know that they're not in there, but certainly they should be, if they're able to do either phone calls or video chats with their family members, or see them through window visits, or however, to really be paying attention to what they, their appearance and their behaviors, and kind of, how they're interacting with you, and ask questions of the staff about what's going on with them.
Well, one of the other symptoms that I didn't mention is slurred speech. So if you can hear on the phone. So if you hear that someone's speech is being slurred, you should absolutely file a complaint with the state survey and cert agency and try to drive them towards making a complaint survey in that facility. Because if your resident, if your family member, your loved one is suddenly getting drugs that you didn't know about, it's happening more than just your resident. So you need to really, don't ever hesitate to file a complaint with the state. And I think it's critically important that we continue to push for that. The other thing I wanted to quickly say, Lori, is one thing that you and I talked about, that another piece of this is patient dumping. That if people are getting drugged against their will, chances are this is also a facility that might be looking to dump out people who are, what in their minds more complicated, require
Right.
more staffing. And then from the residents, from the facilities perspective, disruptive in their minds. So these are two sides of the same coin. That the chemical restraints and patient dumping are two ways to quiet down residents if you are a facility that is inclined to do that.
Right.
So I also urge that on the advice of Lori, that people should continue to file administrative appeals if someone is involuntarily removed or discharged from a facility
Mhm.
for whatever reason.
Absolutely. Absolutely. Let's talk a little bit about what a person's rights are related to medication and directing their care, and do they have to take these drugs if they're prescribed for them? So can you talk a little bit about that and a little bit about getting consent for them?
Yes, so under every state law, and under federal law, you are not allowed to give chemical restraints to a person. So a chemical restraint would be one that is not clinically appropriate. But if you, in order to have that conversation, like I can't just say, Lori, I'm going to give you this pill and you have to take it, no matter where I am, because that would be, and if I force Lori to take it, that's a battery on her body. Like that's a unwanted touching and unwanting forcing something on Lori. And so the same is true for nursing facility residents. And that's part of the difficulty, is that some nursing facilities believe that by consenting to come to a facility, you are consenting to all treatments that they're going to, provide you. And that is simply not true. The requirements under the law are that in order to prescribe a medication and administer it, you have to get informed consent. If a person lacks the ability, the capacity to give the consent themselves, then there's a list of decision makers who should be consulted, and consent should be obtained from those people. So they could be surrogate decision makers in your family. They could be someone you gave a medical power of attorney to, or if the person had a guardian, it has to be that person. But there should always be informed consent, not just consent, not just I'm passing you this, and then if you want your mom to stay in this facility, you better sign that form. That's not informed consent. That's
Right.
coercion. And so you have the right to get the information about why you're getting the drug, about what the side effects of the drug would be, the cost benefit analysis of the drug. You might get this side effect, but we think it's going to treat this. And so you get to weigh those things and decide with the information about whether it's the right choice for you. But if you're to have a real and frank conversation with somebody about giving someone a black box warning drug, it says right on it, if I give this to you, it will increase your chances of death. That is a fact that should be provided to somebody. That's real information that I would want before I accepted a treatment that it could kill me. I mean, that's what a real informed consent conversation should be with these drugs. And I have never heard of anybody in one of these facilities getting that kind of information about.
Yeah. I think that that's right. And I think people need to know that these drugs, when they're used off-label like this, they are not prescribed treatments for dementia. And I think people don't always understand that. So it's important for them to know that they are not approved treatments for symptoms of dementia, which I think is also why they need to be asking questions. And we, as you know, Kelly just released a new resource for family members about a new drug card of questions that people can ask of their caregiver to help them decide whether or not this is appropriate, or at least help start the conversation about what treatments are actually appropriate in these situations. So that's something that folks can get on our website at www.theconsumervoice.org. That's available there for download, and we have hard copies of that available as well. So these drugs have been prescribed not only as an ongoing prescription, but they're also used pretty widely as PRN, aren't they, for people? And so there are, which means on an as needed basis, which gives the the nurse or the caregiver a lot of discretion in when they're using the drug. But in all situations, they should be monitored, aren't they? And evaluated as to whether or not it's appropriate for use.
Right. And so some people can take these drugs and have very little reaction. Others, it just takes one pill and they will have an adverse reaction. So there are, it being PRN does not eliminate the risk by any stretch of the imagination, because it depends on your blood chemistry, whether you'll be one of those unfortunate people that it doesn't take prolonged use to have a bad reaction.
Mm-hmm. Absolutely. And for regardless of whether they're an ongoing prescription or used as PRN, the facility has a responsibility to evaluate the appropriateness of the drug, and also to look at how to wean the person off of it, to decrease either the dosage or the frequency of use until they're not having to have it anymore. So that's a really important point too.
And again, that also requires informed consent, even to take somebody off of the drugs, because taking them off the drugs, if you do it too quickly, can also have very bad adverse effects. So the changes in the administration of the drugs, either up or down, should have informed consent, and the family and whomever else should be aware of what they should be watching for.
Absolutely. So what would you recommend that family members do, or even residents themselves do, if they have concerns about the drugs that are being prescribed, or they have concerns that they're being used as chemical restraints?
Yeah, I mean, I say this about nursing home residents, but anybody who's being prescribed an antipsychotic drug, your first question has to be why? What do you expect this drug to do? Why this drug? What is the diagnosis that you think is the underlying problem for me? What makes you think that? Like, where's the assessment of what you think this drug will do for me, and what are the things I should be worried about? What are the alternatives to this drug? Are there any alternatives? And if you don't know that there are alternatives, you've got to ask as many questions as you can about the why, the what do I expect? Are there things that we could do short of drugs? And what is it that are the risks? What are the real risks, the real life dangers of taking this?
Mm-hmm. Absolutely. I think asking the questions, and that can be done just directly with the healthcare provider, but they can also be asking for a care planning meeting where they can reassess the needs of the individual and looking at what the plan of care is for that person, and looking at the non-pharmacological interventions that are being prescribed, and really insist on those.
Yeah. Well, and I also think that some people are just going to never want to be in a nursing facility. And so if they just don't want to be there, they should also ask for help to get out. And if that's really what the problem is that they just are unhappy and the isolation is just too much for them, they want to get out, they need to try to ask that. That is also something to go to the state survey and people about, because discharge planning is also a requirement for the nursing. And that they should also feel free to ask and demand for assistance from the long-term care ombudsman, or from legal services providers, or from their protection and advocacy program in their state. But we need to address this at all sides. It's just, we can't leave people languishing in these facilities, and we certainly can't leave them languishing in facilities where they're being chemically restrained.
Absolutely. And you referenced the long-term care ombudsman program, which, as most people know, are advocates for residents of long-term care facilities, and they can help them with complaints or concerns about their care. Their services are free to the user, and you can find your ombudsman program again on our website at theconsumervoice.org. There's a map there under Get Help, and you can find the ombudsman that's in your community there. A couple takeaways that I've taken from today that people, I think, need to be aware of is, number one, they need to be paying attention to their loved one and any changes in behavior, changes in condition, changes in the way they're reacting to certain situations, but also to be asking questions about not only the drugs, but the care that's being given or not given, because I think both of those are equally important. And then the third piece is to take action if they have concerns, to not only be asking questions, but get help if they need within the facility or outside the facility.
Absolutely, absolutely. And you know, if I approach things as a lawyer, because that's what I am, but I would ask that you do take action in a way that creates a paper trail. So making a report to the state allows for there to be a paper trail, so that if it happens that people after the fact have to take action, lawyers like me or ombudsman later trying to make sure that other people in the facility are safe, that having the formal complaints made really does help, and we can bring about enforcement. I mean, enforcement is critically important, and I think if you have you in any of your states are seeing that there's a problem with real enforcement, we would like to hear about it at AARP Foundation and certainly Consumer Voice. But we do want to make sure that people are bringing these, any bad care needs to be brought to the surface in order for it to be addressed.
Absolutely. Absolutely. So Kelly, were there any other points that we didn't touch on today that you wanted to make related to this issue?
I think there's a question that just popped up that I found intriguing. And I think the question was, is there a way to make it so that nursing facilities are more willing to train their staff on this? And I've tried to do it by suing them, which is probably not the easiest pathway. The federal government tries to require it in the conditions of participation. Consumer Voice just tried to, and other ombudsmen have tried to do it by corralling, trying to build bridges with providers to try to get them to train their staff. But I think this is a multifaceted issue, and I think Consumer Voice raising this issue up in the way that it is I think a really critical step. This is part of a 3-year campaign that Consumer Voice is doing with AARP Foundation, and we're going to keep. Our goal is to address that question. How do we push this to the providers to make sure that the providers are really pushing out this messaging? The way that Lori and I have tried to think of it is we need to train the nurses, not just the nursing facilities. The nurses are the ones, and nurses and CNAs and the directors of nursing, those are the ones who should be incentivized because they actually do understand how this works. And the facilities themselves maybe have different incentives, financial incentives, but the nurses, I have faith, are going to really push these issues out. And I think that's part of our longer term campaign that the two organizations are trying to work on. But I think it's a critical question, and I think we need to keep, we're open to hearing suggestions about how we might do it, but we need to all work on that together. Really for change.
Absolutely. I agree that it's a multifaceted approach that we need to be targeting everyone, and I think that definitely the nurses, I think a lot of information is being still shared with providers about this issue. And I think that getting family members to understand that this is not okay, that they should be raising awareness and asking questions and challenging the use of these drugs in their loved ones, I think is also critical. Getting a groundswell of support from among family members, I think is also a really important piece. And I think we've been certainly moving in the right direction and getting some good policies in place. It's now getting them all implemented in a way that is going to make the best difference for residents.
Absolutely.
Yeah.
Absolutely. And I think, by making sure, I think one other area to think about it as advocates is making sure that there are good laws on the books in each state to enable people to bring private rights of action to enforce this informed consent. You either have informed consent or you do not. It's a bright line rule, right? And it's a kind of an easy way to enforce your rights. If you never got informed consent, then that's, you don't even have to prove all the damages that happened to you. You can just sue on that alone. And that's, I think, part of this culture change that needs to happen is this. It's not acceptable to drug people with no consent. It's just not acceptable.
Mhm.
And for whatever reason, we've gotten to the point in our society where we think it's okay if they're in a nursing facility, and it's not okay. We
Right.
wouldn't accept it in a hospital. We shouldn't accept it in a nursing facility.
Absolutely. Absolutely. Well, Kelly, thank you so much for being with us today. I think this was really informative. I think you gave great advice, and I look
Thank you.
forward to lots more conversations that we can share with people and resources on this issue. Definitely appreciate your dedication and all of the work that you have been doing, and that of the foundation, which, as you mentioned, is partnering with us on this campaign. We call it Avoiding Drugs as Chemical Restraints, and we have a dedicated webpage that we're continuing to add information to and resources to that we're working on. So our listeners can get more information about that on the Consumer Voice website at, again, www.theconsumervoice.org. So thank you so much, Kelly.
Thank you. Thank you. And thanks to your audience.
Thank you. Thanks for everyone for joining us today. We'll sign off now. Have a good rest of the day.
Bye.